I have Dr. Osman Ahmed and Dr. Sid Padia. Couple things I want to mention though. So GAE and CLI, I don't treat those patients, especially if they truly have CLI. I look at the geniculars as the bypass circuit for the leg, if you will. What do you guys both do there?
Ditto. Same. I mean, I think it's, look, I mean, at the end of the day, this whole hour is about GAE, but this is still unproven territory. This is not the standard of care. This is not in a single guideline by any society. And so we have to be mindful and careful of that. The last thing you need to do is hurt people. And especially maybe not upfront, but like if you jail their collaterals and they need those in a year or two, if they have CLI, that's going to be a big problem.
Yeah, great point. And then also to your point about femoral, I mean, even if I'm going retrograde, I don't feel the need to stick the CFA. I will very commonly stick SFA depending on where the bifurcation is. I don't think twice about it, especially if the groin is a little bit hostile. And you obviously do the same in the integrated approach. And I think this notion that we have to be above the bifurcation all the time is really a fallacy. And it sounds like you both agree there as well.
Keep in mind, Cubby, that the stuff that Oz is using and I'm using is downsized, right?
Yeah, sure.
And I think that's partly why. If you were gonna, I don't know if I'd put an 8-9 French sheath in the SFA. That might be a little bit dicey, right? So
agreed.
But a 4 French glide cath, I don't see an issue.
Well, but like a true 5 or 6 French sheath, even a retrograde SFA approach, I'll still close that, and I don't really have a problem with that, right? And then Oz, to your point about the OBLs, I think that's a little bit of a tricky one for us, right? I mean, time, recovery, patient throughput is very important in the OBL setting. So I understand the interest in going in that direction, but to your point, to Sid's point, actually doing the embolization can be much more challenging. So I know we talked about both of you don't close sheaths versus sheathless. Catheter selection, Sid, microcatheter, microwire choices for both of you?
So if I'm doing an ipsilateral approach, I do a 4 French glide slender sheath, 4 French glide cath, and a 1.7 French microcatheter. Right now, what I'm using is a Echelon 10. I'll be honest, I don't know if it makes a big difference which brand you use. This is just what we kind of started with, but I would advocate for smaller microcatheters, right? We started with 2.4 French. I felt like it was too big.
Oz, 1.7 versus 2. What do you think?
I use 2, and I know probably this will get into our conversations about embolic, but I think going to a temporary embolic, I use, I think it's probably well recognized that I use the plyo joint for a lot of my cases, where I don't think you actually need to go distal anymore. You actually just kind of go proximal or mid and basically go to stasis. So I kind of follow Sid's advice that for me, actually doesn't really matter anymore, like what the catheter or wire is as much. Obviously you want to be small, you don't want to be spasming and doing things like that. But for me, I still use a 2.0 True Select and probably don't even need to use that personally, but it's just what I use and what I'm comfortable with.
All right, great to know. And then I know you said both of you use a 4 French glide cath. I think there's some maybe a little bit of misconsensus, in the community about what type of glide cath to use. I just want to point out that there is a 4 French double braid, there's a 5 French single braid, and a 5 French double braid, right? And the one that I never use is a 5 French single braid. There's no torqueability whatsoever. But it sounds like both of you are using the 4 French double braid.
Yep, I use Cobra. I don't know what shape you use, Sid.
I just use a 4 French angle glide cath.
Okay, got it. All right, let's move on to topic 3. And I think as a precursor here, the three of us probably all do almost the exact same thing in practice. It's basically cancer and pain, right? Probably. And Oz, I think you're a little bit more on the pain side. Please correct me if I'm wrong. Sid, you're probably right in the middle a little bit, and I'm still a little bit more on the cancer side, specifically liver cancer. So all of us are used to doing cone beam CTs everywhere, right? So is cone beam CT helpful intraprocedurally, non-selective and or selective? Oz, you got the no. Sid, you got the yes. Sid, why don't you start?
So I think it is helpful. I would still say the majority of my practice is cancer. And so that's when I learned to do it back in residency and fellowship, and it became kind of just part of your workflow. I find doing a cone beam CT extraordinarily helpful in figuring out which arteries I want to address. Once you get used to it, just like anything else, it's an extra 3 minutes. It really helps pick out a lot of vessels that you would not normally have picked out on a non-selective, let's say, distal SFA angiogram or a popliteal artery angiogram. There are times where you're just not going to light up an artery that well. And that's in part because your popliteal artery is big. Your contrast is going to settle kind of towards the floor, right? So, anything that that courses anteriorly towards the ceiling, it doesn't get as opacified, right? So that's why it doesn't opacify sometimes as much. But with the cone beam CT, you overcome those barriers. And we did a study of over 200 patients, and we found that we did kind of this blinded review of people looking at the angiograms and then people looking at the angiograms in addition to the cone beam CT, and a bunch of more targets were chosen. And so if you go with the hypothesis that more targets is better or more appropriate targets is better, we're looking at like anywhere from a 13 to 15% improvement, which is very significant in my opinion. I think it's quick, it's very easy to do. And I would advocate that everyone should start doing this for GAE.
All right. I hear you, Sid. I'll give you that. I think using cone beam or cross-sectional imaging, definitely, because it applied to me too, is, when you start out doing this, you should do it. It's a new territory in terms of anatomy, recognizing vessels, all that sort of stuff. Now, I think whether to use it routinely, I would probably say I don't think it's needed. The anatomy actually is pretty routinely recognizable. Each artery kind of has a very characteristic, shape, origin. The variants are relatively easy to recognize. So I think in the more intermediate to advanced user stage, you probably don't need to use it. And I think your data obviously is very, compelling, but still, I don't think there's any data clearly that says, well, cone beam improves outcomes per se. It does probably, obviously, may help increase recognition, but I think to use it routinely probably is overkill. That's just my opinion.
Yeah, and I would say that would be the same argument that was used for liver cancer 10 years ago, right? Every single person debating against cone beam in 2015 said, oh, once I'm used to it, I'm advanced, I know how to do, I've seen 1,000 hepatic artery angiograms. And I would argue in let's say, if you're doing a chemoembolization or radioembolization, it's pretty much standard of care, right? So I find that there are enough variants. There are times where I didn't pick up an artery or I couldn't find the angle. It actually makes you can lay out the exact angle you want. So it actually makes the catheterization faster for me. The additional 3 minutes that it takes for me to do a cone beam CT, that to me is not enough time lost to allow it to go to waste.
How about we settle on this? Whenever I'm embolizing a knee osteosarcoma, I'll use cone beam CT.
Fair enough.
Well, and I'll say it this way. I mean, to me, in the liver space, cone beam is standard of care, I would say. Whether controversial or not, it is standard of care. There's no question, right? When I do a non-selective cone beam, I can actually pick my treatment spots and go to those individual spots based off that non-selective cone beam and save a tremendous amount of time in contrast and radiation. So it's not even, that discussion is out the window at the moment. Whether we're going to get there in the MSK space, we'll see. The challenge to me is in the OBL setting, right? And I'm not trying to degrade our OBL colleagues. They do wonderful work. That's not the point. But obviously, there's a reason why there's not a lot of liver cancer treated in the OBL, and there's a lot of MSK embolization in the OBL. So a lot of our OBL colleagues don't have access to cone beam. So if they're starting a GAE practice, how do we do that? What's the right way to do that? I mean, safety first, right? So yeah.
Yeah. So I would say, look, I mean, our group has 5 OBLs. So I'm a big proponent of the OBLs. We do our GAEs, a good proportion of them in the OBLs. The OBLs were not designed to cheat. They're not designed to circumvent or lower the standard of care. If you think you're doing a procedure or taking care of a patient in the hospital, and then you're like, okay, I'm going to take care of the OBL, but I'm going to do it at 70% quality, that's not acceptable. I don't care if they're getting out in 20 minutes. That's not good enough, and we should be better than that as interventional radiologists. Our whole entire profession was based on the fact that we can use advanced imaging. So if you got some crappy third-rate C-arm that you paid $50,000 for, and this is what I have, too bad. Then you shouldn't do this. That's all there is to it. Just don't do it. Save us all, spare us all this, I don't have this capability. There are lots of portable C-arms now with cone beam CT capabilities. I would encourage anyone who's opening an OBL, and again, we have lots of them, to invest in getting state-of-the-art equipment as much as you can. It is, I would argue, becoming more and more cost reasonable over time. So what I would advocate is to not cheat patients. Like, if patients were to find out, I can get this treated by Dr. Ahmed at University of Chicago Hospital, or I can get it treated down the street at an OBL, but it's only going to be 70% of the quality. But hey, they have free parking. I'm going to go to University of Chicago. because it's not like I have to go to get this done every week, right? So go to, I would advocate to strive for the best quality you can.
Yeah, it's hard to argue against that. I think I agree with everything that you just said, with the caveat that then let's get the data out there to prove that cone beam truly is better, and I'm happy to help you do that. And I agree with you that this goes back to one of your original points, which is very important, which is safety. This is not a standard of care intervention. It's not any treatment guidelines, but yet a lot of people are doing it, and the only way to screw this up is by sort of doing it for your first time, not using I would say an alternative to using cone beam is get like a proctor, come visit Sid, go watch him do cases. That's what we all did when we started. I texted Sid, or I called people and asked them for advice. Don't just start doing this, causing complications, getting in the newspapers or FDA advisories, things like that.
Yeah, great point. Great point. Both of you, great points. And then obviously cone beam in the knee is a little bit easier, right? Because it's a non-moving target. You don't need to have breath holds, things like that, right? So even if it's a longer acquisition sequence, it's going to be more tolerable with some of the C-arms that we see in the OBL setting. All right. So with that, Sid, what is your cone beam CT protocol, selective and non-selective?
Yeah, so we do it selective. I think either one is fine. So we do it non-selective. So what that means is we have our catheter in the superficial distal SFA, and then we do the angiogram. We do a regular digital subtraction angiogram, and then we do a cone beam CT where we're injecting contrast from our base catheter. The settings itself, I don't want to go into the details of all the little settings, but basically we're just doing kind of as full field of view as possible. We're looking for the arterial anatomy, and we're looking to see what perfuses the joint and specifically what perfuses the areas of pain. And by doing a non-selective, you can get an outline of all the genicular arteries. You can figure out based on that which ones you want to target. You can look at your MIPS to figure out which angle, if I want to do this at an RAO 25 to figure out to light up the left superior medial genicular artery. It makes it relatively simple. The other algorithm is to do it selective, like once you're in the genicular artery, and then you can do a cone beam CT to confirm that this is what you want. There's no non-target, et cetera. I think both techniques are fine.
What do you think, Sid? Like a 3 for 30 if you're doing non-selective, maybe a 0.5 for 5 if you're selective, 0.3 for 3, something like that?
Yeah, so I draw it out a little longer. I go like 3 for 50, 3 for 60. This is diluted contrast. It's not full strength because, as you mentioned earlier, you're in the knee, right? So you don't have to penetrate through a ton of muscle and fat and so on, right? So the resolution is extraordinarily good. And so 3 for 60 sounds like a lot of contrast. It's not that much. If we do 2/3 contrast, you're using 40 cc's of contrast. The rest of the case, you're using 20. So, it's still 1/3 less than half of a CT scan.
Got it. And then Oz, contrast type, contrast solution, just DSA in the leg.
I'll echo what Sid said about the amount of contrast you need to use. I mean, I routinely, I looked at all my data just recently. The vast majority of our cases are between 20 and 35 cc's of contrast. And that's really because we just dilute the heck out of it. You can dilute that 30 down to 100, and in the leg, even if they're 400 pounds, it's still very, very, high quality, angiograms that you can get. So like Sid said, is a procedure you can do with minimal contrast.
I mean, I've done patients with creatinines of 2.5. When you're using 25, 30 cc's of contrast and you give them plenty of fluids afterwards, even with a high creatinine, you're okay.
Well, I think it's a great point, but also, using 100% contrast can be challenging for these patients, right? Like, it's painful going down the legs. They don't like it. Visipaque or non-Visipaque. I mean, I know, the traditional thing was to use Visipaque, but I still dilute it at least 50% in the leg. I don't know. It sounds like, Oz, you're in the 33 to 50%. Same for you, Sid. Sorry.
Yeah, I mean, we use Visipaque 2/3. So, 66, whatever percent contrast. But you're right. If you go stronger, it'll hurt.
Okay. All right. That's helpful, guys.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.